Hello and welcome. My name is Roberta Watson from Jefferson's Office of Alumni Relations. Thank you so much for joining us for this evening's The Power of Pink Breast Cancer Awareness Must Knows. All of us have been either personally affected by breast cancer or unfortunately have had a loved one who's gone through. So tonight's presentation is extra special. We will be joined tonight by Dr. Ana Maria Lopez, who will be sharing the various treatments, preventative care, and more with us. There's been a lot of breakthroughs, so we can't wait to learn more. Throughout tonight's talk, we invite you to share any questions that you have using the Q&A button at the bottom of your screen. If you don't see that button, try moving your cursor and it should appear. After Dr. Lopez's presentation, we'll try and get to as many of your questions as possible. Now, it's my pleasure to introduce you to our speaker, Dr. Ana Maria Lopez. Dr. Lopez is a board-certified medical oncologist that specializes in women's cancers, integrative oncology, and cancer prevention. She received her medical degree here at Jefferson in 1988 and has gone on to have a tremendous career. She's a telemedicine pioneer as a founding medical director of the Arizona Telemedicine Program. She served as the first Associate Vice President for Health Equity and Inclusion at the University of Utah Health. She's a funded researcher and is a recognized expert with 90 peer-reviewed articles and multiple book chapters. Dr. Lopez has a long history of getting involved in various national boards and continues to serve in leadership positions, including as the President Emeritus of the American College of Physicians, the largest medical society in the United States. Dr. Lopez is now back at Jefferson, and she serves as a professor and vice chair of the medical oncology department at Sidney Kimmel Medical College. And she serves as the chief of cancer services at Jefferson Health, New Jersey, the Sidney Kimmel Cancer Center, and the NCI designated Thomas Jefferson University. She practices in both New Jersey and Center City, and we are thrilled to have her. Dr. Lopez, you have quite the CV, and we're so appreciative of you joining us for tonight's talk. I'm going to hand it over to you to get us started.
Thank you so much, Roberta. It's really a great pleasure to be here, and I want to thank the Alumni Office for all of their great work in putting this series together, and all of you for being here today. So let me just get to the screen share, which I think may be the most difficult technical experience here. Great, so we'll be talking about breast cancer and breakthroughs that have happened. I'll also I know that not everyone is a medical person who has signed up for today, so I also will share just some major changes in the care of patients with breast cancer. And I very much look forward to any questions that you may have. So we'll talk about some breast cancer facts, some breakthroughs, and some innovations that are in process. So first, we need to really remember that deaths from breast cancer have declined since 1990, and they've declined by about 90%. Now, some of this is probably due to increased awareness and education. So certainly people talk about not just breast cancer, but cancer in general more often than they used to. There's just increased awareness of risk. There is early detection, and it was in the 1970s that early detection really became much more prevalent, and women were getting mammographies, and there were guidelines about how to do this. Plus, there are better treatments, better approaches to prevention as well. Very significant, the Women's Health Initiative and the change in practice regarding hormone replacement therapy. But still, breast cancer remains the most common cancer that is diagnosed in women, not only in the US, but globally. So we need to think of breast cancer as a global problem. And it is the second most lethal cancer in women, second only to lung cancer. And that fact has been there forever, that the most lethal cancer in women is lung cancer. 25% of all new cancer diagnoses in the world are related to a breast cancer diagnosis. So a very common cancer, certainly improvements, and we want to look more closely at different aspects of this diagnosis. So I know a really, really common question, and something that I tell you that it's top of the mind for anyone who is really involved in breast cancer screening, who is really committed to early detection, is the issue of screening. Now, mammography is our best test to date, but what's the problem? There are multiple guidelines, and as you can see from this slide, not everybody thinks the same way. So some say start at 40, some say start at 45, some say start at 50, some say, start at 40, but no later than 50. So that's a concern. Some say stop, well, there's no real age limit. You just have to tailor it to the patient. Some say age 75, some say 74. Some say, well, we don't really know. And some say when life expectancy is less than 10 years, which is not always an easy calculation to come by, I think all of us know. And the interval for screening. Some say annual, some say, well, it depends, could be every 1 or 2 years. Some say for sure every 2 years. Some say annual between 45 and 54, and every 1 or 2 at 55 or older. So a key area is for there to really be not sincere, but a significant effort at reconciling these guidelines, and something that cancer centers are doing, including our own, the Sidney Kimmel Cancer Center, is deciding, well, here's how we interpret the data, and here's how we are doing this as a health system. But clearly, if we had better guidance from a national perspective regarding the efforts, and where we're going is probably to a more tailored approach, to really thinking as we look at the different risks for the individual, whether it be family history, whether it be breast density, that there could be better recommendations, not only when to start, when to end, but also what the right interval might be, and even what the right test might be. Because although mammography is our best test to date, there are concerns. Now, you know that every test has false positive and false negatives. And this is also true for mammography. And one of the worrisome factors, and certainly has been a topic of many, many discussions, is that false positives yield the need for unnecessary testing, yield the need for tremendous stress for the patient. On the other hand, others would argue, yes, that may be unnecessary, but important to identify disease. So really how to weigh false positives and false negatives may be very individual, but over 10 years of annual mammography, the chance of having a false positive result at some point is fairly high at about 50%. And there are also false negatives where the patient has a test, understands that the results are negative, but there is disease that's present. Probably women with dense breasts, women in the younger age group, and we had discovered in the Women's Health Initiative that women are on hormone replacement therapy are the ones who may be at greater risk for experiencing difficulties with mammography from a false positive, false negative perspective. So our best test, but not a perfect test, and again, no test is a perfect test. So we need to, and we are studying, are there other modalities that could help us detect cancer early and perhaps narrow that false positive, false negative rate? So are there new approaches to early detection? Contrast enhanced mammography is something that we have access to and that we're looking at really evaluating. at our site. And there is a benefit for contrast enhanced mammography to women who have dense breasts, standard for women with denser breasts. And you can, you're probably aware or are now aware that dense breasts are on a continuum. There are mildly dense, more moderately dense, and then more definitely dense breasts. Often MRI may be used as an adjunct for those patients, but not everyone can do MRI. So contrast enhanced mammography is less costly than MRI, does require the IV for contrast. So if there's a concern of allergy risk, this may be difficult. The patient would need support for kidney function, so people are advised to stay hydrated. And the study is a little bit longer than standard mammography. But you can see in the images, and I'm always amazed by mammographers, because it really is a bunch of shadows, and it's really interpreting those shadows. But you can see the difference between the conventional mammogram and the contrast enhanced mammogram in really identifying the area of concern. So contrast enhanced mammography is one option. Molecular breast imaging is another modality that's being studied and that we're looking to bring to our campus for study. And here, a radioactive tracer is the sort of dye, is what is being used to help find the breast lesion better. I used this image so that you can see that really the process is very similar to mammography. The difference is in the use of the radioactive tracer. And once again, you see the overlay of shadows and just how much clearer the image is with the use of molecular breast imaging. That again, that the radioactive tracer that is used is concentrated in the lesion that is actively proliferating, in the malignant lesion, and is therefore more easily detected on imaging. So imaging, an area for tremendous study, opportunities there for improvement. And as we have diagnosed, as we have identified lesions that perhaps may not have been identified before, we are finding pre-malignant findings. And a question, really comes up is, again, as we think of these lesions along a continuum, can we identify them earlier? Can we make a difference if we identify them earlier? What is this process of continuum? But more of these pre-malignant breast changes are being diagnosed. These are atypical ductal hyperplasia, atypical lobular hyperplasia, and lobular carcinoma in situ. So these are changes that, again, are thought to be pre-malignant. Let's take a look more closely. And you remember that the breast is made up of lobules and ducts. So atypia in any of those areas can be a concern for pre-malignancy. So how is the diagnosis made? Usually there's a lesion that's seen. It may not be what we're looking for. It may not be what we hypothesize is there with the abnormality, but it's what's found on biopsy. It may be an incidental finding, that is, a woman goes in for breast reduction surgery, no evidence of a problem before, but something is found at the time of biopsy, of excision. But what's really important here is that the epidemiology is not really well understood. So we think that these are pre-malignant changes, but we don't really know. We can't really say, here is a typical ductal hyperplasia, and now we follow the patient, and now it has become this pre-malignant change, and then this next pre-malignant change, and now it's frank malignancy. We don't really know the rate at which these changes progress to cancer. If they definitely progress to cancer, what the factors are that stimulate the progression to cancer, or what the factors might be that definitely will limit the progression to cancer. So a lot of questions. Now we hypothesize that this is a linear process, but again, we haven't really done that study. And of course, that study would be very difficult to do, where we could really track a normal breast, identify changes, and then really note and monitor how these changes move from a normal state to a frankly malignant state. But the concept is it's linear. We just don't have all that data to say for sure. So as an example, I give you how we manage lobular carcinoma in situ, and the differences over time. I think medical history is just fascinating. So here's just an example. So in 1941, lobular carcinoma in situ was identified, and it was identified as a carcinoma. And because of that, the treatment was mastectomy, which was this is the treatment for cancer. In the 1970s, the whole concept of bilaterality, and not only mastectomy, but contralateral biopsy was introduced. In the 1970s, we've mentioned that screening increased breast cancer awareness really came into the forefront, and people, were starting to use mammography much more. And the observation was then that after the diagnosis of LCIS, invasive breast cancer was not always present. It was not a common finding. In 1985, lumpectomy was established as an alternative to mastectomy. And in 1986, there was another report that said, most diagnoses of LCIS do not lead to invasive breast cancer. So in 1996, and really currently, excision of that part of the breast, of that lesion, is thought to be helpful management for this finding. So if a core biopsy identifies, again, usually these would be, there's an abnormal mammogram, there's a biopsy that follows, that if these pre-malignant changes are identified, atypical lobular hyperplasia, atypical ductal hyperplasia, lobular carcinoma in situ, lesion excision is recommended, but partly because we know that anywhere from 17 to 50% of those lesions will have in situ breast cancer or invasive breast cancer in that same lesion. After excision, close follow-up is necessary, so that if dense breasts are present, consideration of breast MRI, if there's a family history, consideration of genetic counseling and testing, and perhaps discussion around chemoprevention, which is generally hormone blockade therapy, which can be tamoxifen for premenopausal, postmenopausal women, and a class of medicines called aromatase inhibitors for patients with who are postmenopausal. So chemoprevention is an area that really is open to a lot of study, just requires a lot of patience to make a significant finding. So finding pre-malignant lesions is an area of study, of change, as we've seen. Now, what if risk reduction is necessary? And certainly knowing that in the United States, 1 in 8 women are expected to be diagnosed with breast cancer, knowing that 25% of cancers globally are breast cancers. Breast cancer risk reduction is also an area of tremendous study, and really an area that I think is very important for all of us to think about. And I'm going to talk about lifestyle here, because we really do understand that cancer in many ways, and breast cancer included, is a disease of energy imbalance. So energy balance, meaning energy coming in through food and energy going out through physical expenditure, through physical activity. Energy balance is very important for breast cancer risk reduction and for several other cancers as well. Now, generally, when we think of metabolic changes, when we think of energy balance, we think about weight. Now, what weight, when and what weight do we need to be thinking about? Important to think about postmenopausal weight gain. Important to think about weight gain during adulthood, because very, very interesting that a woman who has been overweight or even obese throughout her life may not have as high a risk from breast cancer related to this energy imbalance as a woman who may have had a normal weight, let's say, during her adult life and then began to gain weight in the postmenopausal years, or who gained weight throughout adulthood. So this concept of energy balance and stable weight is very important. Now, why is this? We don't know fully. We do know that increases in weight can be associated with higher blood insulin levels, which can be a risk factor for breast cancer. We also know that estrogen is carcinogenic from a breast cancer standpoint, and that after menopause, although the ovaries are not producing estrogen, estrogen is being converted in fatty tissue. So perhaps there's increased estrogen exposure during those times of weight gain. And those changes are what is the issue. The type of breast cancer that this is most associated with is endocrine sensitive breast cancer. So hormonally positive, hormonally sensitive breast cancer. Alcohol does appear to be a factor here as well, and likely related to this metabolic issue. A linear relationship is present in the sense that 1 drink of alcohol per day appears to increase the risk by 7 to 10%. 2 to 3 drinks of alcohol per day seem to increase the risk by 20%. So a linear relationship in risk. And the advice for most women is really to drink as little as you can, as little as you, and even none, really related to this whole issue of risk. Physical activity, again, we are in this concept of energy balance. Regular physical activity, really maintaining this energy balance, staying active, is very important from a breast cancer risk reduction standpoint. These recommendations come from the American Cancer Society, which has recently updated its nutritional and physical activity recommendations. And 150 to 300 minutes of moderate physical activity weekly. So I think important to note that this is weekly, so that this can definitely be divided in smaller chunks over the week. Could be 30 minutes of walking, at a vigorous pace most days of the week, for example. But it's very important for us to remember that from what we are learning, we all know the risk related to tobacco use. Being sedentary is really being considered the new tobacco-like risk, the new smoking type risk for breast cancer. I do want to share, and this is again from the ACS, because a very common question is, what do you mean by moderate intensity? What do you mean by vigorous intensity? And again, these do not have to be at one sitting. This could be multiple types of activity during the day. But the main message is be active. Really keep your body strong throughout your life. Now, a question that often comes up is, what about hereditary breast cancer? And we know that 5 to 10% of breast cancers are related to a genetic component, but we used to only be aware of BRCA1 and BRCA2. We now know that there are many, many genetic mutations, and that if we really identify breast cancer risk earlier, hereditary breast cancer risk earlier in life, that allows the person to make decisions. You know, if they find out that they have hereditary breast cancer, do they want to have breast reducing surgery? Do they want to do they want to reach out to other members in their families to get tested? So how do you know if the person may be at risk for hereditary breast cancer? Most important is know your family history. This is something for each of us. This is something for us to share with our family members, and this is something for us to share with our patients. Know your family history. Women diagnosed with premenopausal breast cancer, know who in your family has had breast cancer. One or more members, two or more members, were they diagnosed at before menopause? Ovarian cancer can be linked with breast cancer. Is there a male relative with breast cancer? And does the family have Ashkenazi Jewish ancestry? So these are some of the pertinent historical factors that can guide us to knowing, is this person at risk for hereditary breast cancer? Now I'll go through some changes in surgical practice and chemotherapy. And the main one that I want to bring to you, I mentioned earlier that lumpectomy and mastectomy, so removing an area of the breast as opposed to removing the entire breast, is a standard option now. But how we assess the lymph nodes has also evolved and changed. And in the past, there would be a lymph node dissection so that this entire area, the surgeons would meticulously go in and remove all of the lymph nodes that they could see. But really, we now know that injecting a radioactive dye allows the surgeon to see in vivo the areas that light up, what are called the sentinel lymph nodes, so that at the time of surgery, when the tumor is removed, the sentinel lymph nodes may be removed. And those are sort of the harbingers, the points to assess first, are malignant cells present in those lymph nodes or not. If malignant lymph nodes are not present in those sentinel lymph nodes, the patient can be reassured that this is a lymph node negative breast cancer. If there are malignant cells in the sentinel lymph nodes, then the surgeon would go in and remove additional lymph nodes. So this has resulted in tremendous benefit for women from the perspective of lymphedema risk. Not that the risk is zero, and certainly by going through radiation, which is part and parcel of lumpectomy assessment for women at most ages. There's studies and options for women who are older, but for women of most ages, lumpectomy is treated with radiation. The risk of lymphedema certainly has decreased with sentinel lymph node biopsy. Some changes in chemotherapy. Now, most chemos used to be every 3 to 4 weeks. For breast cancer and for some other cancers, we have this concept of dose-dense chemotherapy, where the same chemo may be used, but there is less time in between the treatment. So instead of 3 weeks, it may be 2 weeks. And the concept is that you do the treatments in a sequence where you give the cancer less time to grow in between. This has resulted in fewer recurrences for breast cancer, decreased mortality, and again, a very interesting concept that there's not a change in which chemotherapy. There's not a change in the amount of chemotherapy. It's really the schedule that the chemotherapy is given. But let's talk a little bit more about chemotherapy and innovations here. Chemotherapy had traditionally been given after surgical intervention. We are now using the concept of neoadjuvant chemotherapy more and more often. And the rationale is that this giving of chemotherapy first, after the tumor has been identified and delineated, may really increase the possibility for breast-conserving treatment, so may shrink the tumor enough so that lumpectomy may be feasible. But it also gives us the opportunity to see the tumor shrink in vivo and for us to know whether the treatment is working or not. The patients who are most eligible for this therapy are patients with triple-negative breast cancer, even in early disease. So patients who have breast cancer are evaluated for estrogen sensitivity, which means that the breast cancer cells are exposed to estrogen, and then we can see what percent of the breast cancer cells pick up the estrogen. So in a sense, the estrogen is fueling the breast cancer growth. We also test all breast cancers for HER2 positivity, and HER2/neu is a protein that stimulates breast cancer growth. So these two types of breast cancer, triple-negative breast cancer, even early stage, and HER2 positive breast cancer may be eligible for neoadjuvant chemotherapy. That is chemotherapy before surgery. Let's see. We're not advancing. Let me try here. There we go. We used to kind of give chemotherapy to just about everybody who had breast cancer unless they had very small tumors. And what we learned is that we were probably treating more women than needed to be treated with chemotherapy. And we now have, as you know, really more of a reliance on understanding the molecular biology of the breast cancer. And we know through genomic testing, through a specific genomic assay called Oncotype DX, that analyzes 21 different genes in the patient's breast cancer, that we can get a score, a gene expression pattern that tells us, this cancer is more receptive to chemotherapy or less so. And through this score, we can really say to the patient, you need chemotherapy, or your benefit from chemotherapy will be less than 1%. I have to tell you that the use of Oncotype DX, that the use of this genomic assay has really changed how we practice medicine. And now some new classes of drugs. There are 3 cyclin-dependent kinases. And so taking us back to pharmacology, those of us from med school, where these medications actually bind to cyclin-dependent kinases, which regulate cell division. So by blocking these very specific cyclin-dependent kinases, the cells are unable to multiply and cancer cell growth can be stopped. These medications are used in combination with hormone blocking agents. So again, practice changing therapy in hormonally sensitive estrogen-fueled breast cancer, used with the agents that are starving the tumors, the addition of the CDK4/6 inhibitors, really using another path to block cancer growth inhibition. There are 3 agents that have been FDA approved and all improve progression-free survival in patients with metastatic breast cancer that is endocrine sensitive. So this is a new standard of care. I mentioned HER2/neu. HER2/neu is a protein that stimulates breast cancer growth. And you see, regular cells can express HER2/neu, but cancer cells overexpress HER2/neu, so stimulate the cancer cells to grow. Trastuzumab, known also as Herceptin, binds the receptors and stops this signal for cancer growth. Now we have an additional monoclonal antibody, pertuzumab. Pertuzumab works with trastuzumab or Herceptin for larger tumors, lymph node positive tumors, to treat HER2/neu positive breast cancer. So in combination, you see the complementary action for the trastuzumab pertuzumab combination, because what happens is that tumors over time may develop resistance, and this would be a way to overcome or prevent the development of resistance to the therapy. Here is a novel way to not only use the monoclonal antibody, but bring in the monoclonal antibody with a cytotoxic agent into the cell. And this example, again, is in HER2 positive breast cancer. So trastuzumab, the monoclonal antibody, and the cytotoxic agent, the chemotherapeutic agent that is linked to the antibody. Through the binding of the antibody, the chemotherapeutic agent is able to directly enter into the cancer cell and cause destruction of the cancer cell. So a very elegant way to bring chemotherapy directly to the cancer cell, an antibody drug combination or conjugate. This is now approved for HER2 positive breast cancers, and another way to really revolutionize the way that we deliver chemotherapy. Triple negative, we talked a little bit about, that these would be cancers that are negative for estrogen, progesterone, and HER2 protein. About 2/3 of breast cancers are endocrine sensitive, 20% are HER2 positive, and 10 to 20% are triple negative. Now, these cancers are thought to be more aggressive, have a poorer prognosis, and are found more so in younger women, in Black and Latinas, and in patients with a BRCA1 mutation. So these are higher grade, more aggressive tumors. And we're using a combination of immunotherapy and chemotherapy. So what has been discovered, PD-L1 on the tumor cell is a way to mask the tumor cell. The T cell sees the PD-L1 and thinks, oh, this is one of us, and does not attack. The addition of the anti-PD-L1, the atezolizumab, which is another monoclonal antibody, binds and allows the T cell to now recognize the tumor cell. It unmasks the cancer cell, and the T cell can now return to its anti-tumor function. So this is a tremendous breakthrough that really has allowed us to think more and more about how the body's natural immune system can treat the disease. And how it's used is in combination. You have the atezolizumab, which is the FDA-approved anti-PD-L1, in combination with nab-paclitaxel, a chemotherapeutic agent, and together they have been found to improve progression-free survival. Ongoing research questions, overall survival, and benefit in early stage triple-negative breast cancer. Although immunotherapy stimulating the immune system is definitely a positive, I don't want you to think that this is without side effects. And some of the side effects are like usual chemotherapy, meaning hair loss, fatigue, nausea. But some of these are really related to immune symptom reactions. And important to remember that some of these immune-related factors can take place weeks or even months after the therapy. So immunotherapy, now new targeted therapies. New targeted therapies, and this is the tremendous thing, is that as we understand more about the molecular biology, we will identify new potential targets, and this is one of them. The PIK3CA mutation, present in about 30 to 40% of breast cancers, and a new agent that can be used in combination with one of the hormone blocking agents. So we are really at the age of thinking about precision medicine, targeted therapies, and the tremendous importance of understanding the tumor, not only from the histological standpoint, but from the molecular standpoint as well. PARP inhibitors, another example, for metastatic breast cancer, HER2 negative, but BRCA1 or 2 positive. And these may be used with chemotherapy. And what they do is that the PARP is a protein that helps cells repair themselves when they become damaged. So PARP inhibitors prevent the cancer cell from repairing itself. And by this action, the cancer cell does not repair itself, and it dies. So for metastatic breast cancer, we really need to remember the importance of molecular testing. That's why it's bolded, so that we can identify the clones that are supporting the metastatic process, and then identify potential targets, some of which, of course, at this time, will be investigational. What's in development? The incorporation of artificial intelligence can be used as an adjunct to imaging, being looked at as an adjunct to pathological review, and certainly can be an adjunct to clinical support, where we can use calculators for risk assessment, for example, or to identify which treatment may be of greatest benefit in the metastatic setting based on the molecular aspects of the tumor. Nanoproteins. Nanoproteins, these imprinted spheres, a recent study that was published in 2019 that showed that nanoproteins imprinted were imprinted being able to identify HER2 positive breast cancer cells were effective in being able to slow tumor growth and left healthy cells unaffected. Remember that the side effects related to cancer treatment really relate to healthy cells being impacted by the treatment. So if nanoparticles can recognize and detect specific markers that are on the membrane of breast cancer cells, this may be a very effective approach for cancer therapy and for future interventions. We talked about antibody drug conjugates, and I gave you an example in breast cancer, but this concept of delivering active chemotherapy directly to the cancer cell really provides us with the idea of, could this be an approach for other cancers and for resistant cancers as well? So cancer, we know now, is not just one disease. It's not even just one disease in a single organ. This is a multiplicity of diseases. So the road to curing cancer makes sense that it has been long, and we've had multiple home runs as well as multiple not as successful approaches. At the same time, new discoveries are being made every day as we understand the growth patterns of the tumors and as we develop new technologies for early detection. There are many innovations that are in the offing, and this is really quite an exciting time to be in breast cancer care. Thank you so much for your attention, and I think that some questions had come in through the chat. I look forward to your questions.
Thank you so much, Dr. Lopez. That was really insightful, and there was a lot of really great information from that. So
Thank you.
I've had a few questions come through the chat. We actually had a couple already answered about discussing prevention strategies, but one
Mm.
specific in relation to preventative care. So, in your opinion, are taking supplements like DIM to mop up extraneous estrogen along with an improved lifestyle of following maybe plant-based diet and increasing regular exercise? Do you think that's maybe a good way? Can you discuss maybe some different diets and exercise regimens that work best?
Sure, thank you. The supplements, as far as a way of, I like the phrase, mopping up extraneous estrogen, um, we just don't know enough to say that. So there's a lot of study that is needed in the risk reduction area, and really in so many areas of breast cancer as well as cancer prevention and therapy. So I can't say that we know enough. We do know some about the anti-inflammatory diet, and that is primarily a plant-based diet. Inflammation can be a significant promoter for breast cancer and other cancers. And similarly, regular exercise is another anti-inflammatory intervention.
Great, thank you. That was really helpful. So we have a couple of questions regarding density. So at what age do breasts become less dense as part one? And then would you recommend these dye contrast mammographies for a person with intermediate dense breasts?
So breasts do tend to become less dense with age. So after menopause, breasts become more fatty, less dense. Um, and that was one of the findings in the Women's Health Initiative, that women that were on hormone replacement therapy did not lose breast density. Similarly, we know that women on a plant-based diet, and we know this from the women's, it's either the WINS or the WELL study, where a plant-based diet decreased breast density. And decreasing breast density is helpful from a mammography standpoint, in the sense that malignant changes are easier to read. So breast density, yes, less as one gets older. As far as the dye contrast mammography for a person with dense breasts, that is an area of study that may be an indication for women, for example, who have dense breasts, who may not be able to have an MRI, but that is an area of active study.
Great, thank you. The next question we have are, what are your thoughts that stress may contribute to breast cancer?
Sure. So from, again, this whole concept of inflammation, stress also interfering with sleep, there's a whole body of study regarding the impact of sleep and breast cancer. Melatonin exposure, so really sleeping in a dark room, so you have maximum melatonin, have maximum sleep. So again, an area that's being looked at from, something that I talk about with patients, definitely stress reduction, stress management, very, very important. But from a prospective randomized trial standpoint, an area of ongoing investigation.
Great. Yeah, that's really wonderful. So thank you so much for all of your insight during our presentation and for answering our questions. I am going to pull up some upcoming events to share with you all. So again, thank you so much, Dr. Lopez, and thank you to all of you for joining us for this evening's webinar. We will be adding the webinar to our YouTube channel in the coming days, and you'll receive a link to that in your email. So be on the lookout for that. If you'd like to go subscribe to our YouTube channel, I'd highly recommend it. You are welcome to go watch all of our videos on demand, and there are several various topics, so you can kind of find whatever you're interested in there. I hope to see you again at some of these upcoming events. You know, we are in full swing this fall, and we've got a lot of different things going on. If you're interested in similar lifelong learning programs like this evening, we have 4 upcoming events. Our first will be on October 28th, and it will be an update from Coach Shirley on the RAM athletics program, and that'll be from 7 to 8 p.m. Eastern Standard Time. We have a presentation during the lunch hour for our Eastern Standard folks that will be sharing some information on vaccines, including for COVID-19 as well. So you won't want to miss that, and that'll be on November 6th. Our next one is an insider's look into the world of professional baseball. We'll have an alumnus who spent his career working in baseball in various roles, kind of share what he found. So that'll be fascinating. That's going to be on November 9th. And that'll be from 7 to 8 p.m. And then finally, a talk sharing some tax saving strategies that you can use today and tomorrow. And that'll be on November 10th from the 7 to 8 hour again. So if you'd like to register for any of those events and any of the other events that you see on the screen, you are welcome to go to jefferson.edu/alumni events, where you can find more information there. Finally, during this crazy time, we have really been most worried about our students, and this has led us to launch the Reimagine Scholarship Initiative to help our students stay enrolled in this upcoming academic year. When you make a gift today, Johnson & Johnson will match your gift up to $25,000, and they still have money left in their match. So I encourage you, if you're open, if you're able to go donate a gift to either students in the most need or students from a specific program or area of the college that you care for most, your dollar can really make an impact. And you can find more information on that program at jefferson.edu/reimagine scholarships. That's it for tonight. Thank you again for joining us. It's always nice to see everybody virtually, and I hope to see you all very soon. Thank you so much. Take care.